Okay, hi everyone, and welcome to SCAN's first virtual Lunch and Learn. I'm Andrea Tarr. I'm the program director at SCAN, and a couple of pieces of info that I just want to let you know about. First of all, we are recording today's webinar, and we will make that available to everyone. Since we do have your email, we will be putting the webinar will be going on SCAN's YouTube channel, and we'll send you the link to that. So that will be easy for you. And also on the bottom of your screen, you should see a little chat feature. And I'm directing your attention to that because if you do have a question for either of the presenters, you can just go ahead and type it in the chat screen. And we'll be monitoring the chat screen. And at the end of each presenter, we will have an opportunity for Q&A, all right? So without further ado, let me introduce my colleague, Mary Beth.
Hello, everyone. I'm Mary Beth Kwapniewski. I'm the program coordinator at SCAN. Again, welcome. We have two wonderful presentations, and our first presenter is Dr. Dessalines. He is representing Care One today. Care One has 4 locations, and it's their Homedale location that Dr. D is presenting today. So Dr. D, I'd like to invite you to join us on camera.
Come on down. There he is. Hi, Dr. D.
Hello. Hi, everyone. It's a pleasure for me to be here with you today. Again, my name is Normy Dessalines, and I'm a board-certified internal medicine doctor. My office is in Red Bank on Broad Street, 252 Street, number 1. I am affiliated with most Meridian hospitals, including Riverview, Bayshore, and Jersey Shore. It's a pleasure for me to be here today. I hope to share some relevant information with the audience today, and hopefully we'll have some good questions, and that I'll be able to hopefully answer for you. Something happened?
You're good.
You're good, Dr. D.
Okay.
Yeah.
Except my screen is black.
Dr. D, I'm sorry. You can also change your view up in the right-hand corner so you can see yourself. That really should.
Oh, I got it. Now I see myself. Okay.
All right. We're all learning our technology.
Oh,
all right.
okay. Thank you. Good. Thank you so much, Mary. May I start, or is there anyone else we need to?
No, you're welcome
introduce?
To start your presentation.
Okay. Today I choose, when I was invited to give that talk, I choose preventative care because I feel like it's not emphasized enough in our medical system. We focus a lot, and it's my opinion and the opinion of a lot of other experts on procedures and invasive intervention, and preventative care is an integral part of quality healthcare, which obviously, if you have a certain illness, you should seek the best treatment possible for it. But appropriate preventative care, is important in an attempt to lessen future, healthcare decline. But when we talk about preventative care, it's we need to prioritize because there's so many tests and procedures and formalities that we can use, and they don't always apply to everyone. So we need to prioritize who would benefit the most from the procedure, or what age, you know, the person should be to benefit from this procedure. This is all important. And what I mean by factors to, like I said, factors to consider is, you know, the patient age, the patient sex, and other risk factors such as, do they smoke, are they obese, you know, what their family, you know, history is. So all this is important when we're having the discussion with the patient. Obviously, it goes without saying that any preventative care should go also with the patient preference. You know, some people might say, you know, I'd rather have a stool test than doing a colonoscopy. We can, and again, this can be like a topic for, you know, for another day. But that's also very important. And not all preventative measures are recommended at the same level. And we usually in the medical field, especially primary care, we go by the United States Preventative Task Force, and they have different level of recommendation depending on the level of evidence, you know, on how convincing is the evidence that certain procedure will help, you know, will help improve the patient, you know, quality of care and longevity. So usually we try to convince or try to not counsel the patient about intervention that have level A and B recommendations, and these are the best, you know, the most sturdy, and we have the best data, you know, that show that these procedures they help, you know, like your colonoscopy, you know, your mammogram, you know, your pap smear, which we'll go a little bit more over later. Then you have your level recommendation C, you know, which data show that they might help a little bit, but you know, they can cause more harms than good. And the level D definitely we don't recommend because they definitely cause more harms, and there's no data showing that they help, you know, with improving the patient care in general. And level I are those procedures or the testing, you know, means for which we don't have enough data to counsel for or against. You know, there might be like new testing modalities that we just don't have enough data to, you know, to tell the patient, you know what, we think that this could be something that might be helpful or not, you know. And the reason why we recommend, you know, we go by the level of recommendation A and B, it's because we feel like they cause more benefits than harms. Obviously, you know, when I counsel a patient about preventative care, you also have to let them know what the harms of screening can be, you know, because a lot of time screening can cause anxiety. Some testing modality have a lot of false positive screening slots, such as mammogram. A lot of times you can have, if you do it at the wrong time or the wrong age, you can have a lot of false positive screening tests, you know, and also like positive screening tests. And sometimes also you can overdiagnose a procedure. So you might do a colonoscopy in a person and you'll find something, and now the patient has to go for surgery, and without knowing whether or not, if, you know, had you left this polyp alone, you know, maybe it would have never became, you know, cancerous, you know, in the first place. How how efficiently to deliver, prevention. So that's where primary care is very important. Again, I might be biased. I'm a board certified internal medicine doctor, but that's where we really shine, because you really gotta have a good relationship with the patient, and the patient also have to follow up. And it has been shown, and multiple studies are showed that patient will follow up, on a regular basis with their primary care doctor. They get the best preventative care, and they tend to have a better quality care and better they tend to live longer, and avoid their medical conditions tend to be better controlled, such as their blood pressure, their weight, their diabetes. Again, hopefully we'll have time to answer some your questions. So feel free to put them in the chat box. Well, obviously, we can't screen forever. It is important also, like I said, when you screen the patient, at certain time, you got to discuss, stopping or reducing screening, because let's say for let's take an example for high cholesterol. Usually multiple studies again have shown that for cholesterol medicine to be beneficial, the patient has to have an expected, life expectancy greater than 10 years. So if you don't think the patient, if you don't think the patient has a life expectancy greater than 10 years, it doesn't make sense to screen that patient for high cholesterol, because it's just not going to be pertinent, because they're just not going to benefit from that screening. Again, what we can. So one of the most important disease spectrum that we tend to screen for are cardiovascular disease. And when we talk about cardiovascular disease, we have to talk about their risk factors, such as your diet, do you smoke, your weight, your cholesterol, obesity, how physically active you are, your diabetes. So that's why it's important, to screen for all these risk factors and all comorbidities, So let's start with hypertension. Hypertension, it is recommended to screen for hypertension in every adult above the age of 18, and this is fairly simple. And most patients, when they go to see their doctor, they get a blood pressure check, and that's a good thing. And after that, if in most patients younger than 40 years, you can check it every 3 to 5 years if they don't have risk factors. If, let's say, they're not overweight, their cholesterol level is good, they have no significant family history, they're not a smoker, there's no reason to check a blood pressure, sooner than that. Obviously, it varies also, and also it goes with the patient preference. And hyperlipidemia, cholesterol, it's about the same. So usually it's recommended to check once the patient reached the age of 17, between 17 and 21. After that, every 3 to 5 years, if the patient doesn't have any risk factors or any other conditions that necessitate, sooner, to check it sooner, And next is weight. Obviously, that's very important, because obesity is a major risk factor when it comes to high blood pressure, hyperlipidemia, diabetes, cancer, you name it. Obesity is part of it. So that's why it's important to maintain a regular weight. So it is recommended to check patient weight at least at every doctor's visit, and that's important. And physical activity are also, it goes without saying, because if obesity is a risk factor which we need to control, one of the way to control your weight is by increasing your physical activity. And diabetes, which is another risk factor for cardiovascular disease, you should check for diabetes in all adults aged between 40 and 70 years of age, who have a BMI of more than 25, 25. I don't know. BMI is a measurement of your weight, and other preventative measures. It used to be where everyone, should be like, as long as you have high blood pressure or you're over like 40 or 50 years of age, should be on a baby aspirin. But the data that are coming out are more, they're more nuanced now, and they're recommending having a discussion with the patient. It goes on an individual basis when it comes to whether or not you should be taking a baby aspirin. Again, you gotta remember, like I said, every preventative measures, they come with arms. So you have to balance out the risk versus the benefits. And should we get a routine EKG on every patient? Probably not. And other new novel modality of screening that are coming, it's a calcium scoring. It shows that it can help, but it's mainly the cardiologists who order this test, like a coronary calcium, artery calcium score. But it's a fairly simple test that a primary care physician can also order. And another category of comorbidities that is important also to screen for the cancer prevention. And a number of measures can be taken in order to prevent or reduce, the likelihood of a patient coming up with a diagnosis of cancer. First and foremost, tobacco, and we can't emphasize this enough. If you can quit smoking, this is the best thing you can possibly do for your health, and it's really within your power to do so. It's not like it's a family history that, and it's something that, it's not like it's a medical condition you were born with. So it's within your power. It's lifestyle modification. Again, being physically active, maintaining a healthy weight, eating a diet rich in fruits, vegetables, whole grains, and low in saturated and trans fat, limiting alcohol consumption. I know a lot of people might disagree with that, and protecting against sexually transmitted infection. And obviously, mainly in fair-skinned people, avoid excessive sun exposure. I know it's hard now during the summer, where sometimes we get some really nice day and we are at the beach. We just can't help it. So let's start with breast cancer. So major risk factors for breast cancer are like women age and genetic predisposition. That means their family history and how long they've had their period for, really. And depending on these factors, the timing and the frequency of your mammogram will vary. Usually, they recommend clinicians to discuss breast cancer screening with their patient, once they around 40 years of age, And all women should receive counsel about the benefits and harms of screening and understand. Like I said, you have to understand that a mammogram, it comes with, substantial harms, even though it helps a lot, but you need to remember that mammogram, sometimes you have a lot of false positive findings. What I mean by that, you go for the mammogram, it shows something that's there, but that's not really there in actuality. And then when the doctor sees that, then you gotta go for a biopsy. Then you might end up having surgery for something that's not even there, and that's what we need to guard against. And you usually recommend screening mammography at every 2 years. But again, it's going to depend on your history, and whether your last mammogram was normal or was there something there. In that case, you might do it sooner. But usually, every 2-year mammogram is okay. And usually, it is recommended, like I said earlier, to stop screening if you think the patient life expectancy, is less than 10 years. What I mean by that, if you have a patient with God forbid, end stage cancer, like let's say they have a lung cancer, it doesn't make sense to screen them for breast cancer, because their life expectancy most likely is less than 10 years. And they also recommend now against breast self-exam, because that can cause also a lot of anxiety and false negative results. And if the patient insists on doing it, they need to be taught and educated on how to do the breast self-exam. Now, for cervical cancer, the recommendations usually we start with in women age 21, between age 21 to 65. But again, that could be a topic on its own for cervical cancer, because it can vary depending on the patient, the risk factors, and other medical conditions. But for average risk women, that means they're not immunocompromised between age 21 to 29. Usually a pap smear, every 3 years is fine. But for women older, between age 30 and 64, you can either do a pap smear every 3 years, or you can do a pap smear with an HPV test every 5 years. So the frequency is a little wider if you do the pap smear plus an HPV screening test. For women above 65, if they've had multiple negative pap smear, it's really not recommended to continue it. But if the patient have had some positive pap smear in the past, you might consider, if they have good life expectancy, that means life expectancy greater than 10 years, it's recommended to continue the screening at least until age 70, 75. And for women who have had total hysterectomy for a reason or other, if it wasn't for like cervical cancer or high-grade cervical cancer, there's no reason to continue doing pap smear on them. Ovarian cancer, really for average risk women, there's no data showing that screening for ovarian cancer help with improving life expectancy or medical care. For colorectal cancer, for average risk patient, they usually start at the age of 50 and older. And it's the same thing also. If we usually stop when we feel like the patient life expectancy is less than 10 years. And that doesn't mean that the patient is not worth it, or the patient we're not taking care of the patient. It's just that they're not going to benefit from it. I see Mary Beth now. I don't know. Am I using too much of your time? I'm almost
No,
done.
no, you're doing okay, but I did want to ask, pose a couple of the questions that we've gotten in the chat so we don't run out of time.
Okay.
Is that okay if I jump in?
Sure, go ahead.
Okay, so one of our participants asked if she was diagnosed at the age of 68 for high blood pressure and put on medication, do you think that she would ever be allowed or permitted to get off of it? Is it a long-term medication that she would have to take?
Oh, that's a great question. Again, it's gonna depend on the patient risk factors, and the patient comorbidities, and hopefully, she's not overweight. Hopefully, she doesn't have a history of a heart attack or stroke or in the past. Hopefully, that patient is not a smoker. Then, in that case, if the blood pressure is able to get to improve, with treatment, and the patient is also on a diet that's not too high in salt, the patient can watch their diet and can exercise, it might be able to come off the blood pressure medication, but it's very rare.
Okay, all right.
It's not easy.
And we have a question about if you had to recommend the top 2 screenings for men and women to have annually, what would those 2 be?
Top 2 screening would be check your blood pressure, go see your primary care doctor, at least get a blood pressure check, and also get a physical exam. That would be the top 2, because that's where everything else fall in line. If you don't see your primary care doctor, and then you're just gonna get lost. A lot of time you see patients seeing specialists without seeing a primary care doctor, and that's where they can get into trouble. Because again, when it comes to preventative care, you have to take the patient as a whole. There's nothing is set in stone. You have to consider patient age, the patient risk factor, the patient comorbidity, the patient other medical conditions.
Okay, and we have a question regarding flu shots. Flu shots a must for this fall, especially with everything going on?
Yeah, that's without a question. Now in the time of COVID, it's gonna be even more important to get your flu shot. And again, like I might be biased, but this is the best time to really stay in touch with your primary care doctor. Make sure your blood pressure, your weight, your diabetes, because all these will help you fight the flu and the COVID better. So the flu shot definitely, is a must. Don't. It helps, and there's plenty of data that backs that, and there's
a pneumonia vaccine for our older population as well.
Yes, if you're due for it, definitely get it. If you're diabetic, even if you're younger, even if you, as long as you're older above 19, if you're diabetic or if you're a smoker, you should get the pneumonia vaccine also.
Okay.
Yes.
Okay. Just gonna give it one more. Okay. Any closing comments you would like to have our participants hear from you?
What I would like to say again, thank you for having me. It was a pleasure to share this information with you. Again, it's very important to stay in touch with your primary care doctor, because they're going to be the one really to make sure that you're getting the preventative care that you deserve and need. And they're going to be the one to sit down and have the discussion with you and go over, because it has to be it has to take into consideration the patient preference as well, and the patient lifestyle.
Great, wonderful. Well, thank you, Dr. Dessalines, for being one of our presenters today. We will have an email that follows up after our webinar, so your contact information will be included in that. So thank you very much for joining us today.
Perfect, Maribel. Hopefully we'll get to meet in person soon.
Good, I hope so. Okay. I'm going to switch to a...
First of all, thanks for the time. Honestly, thanks for having us. And I appreciate the folks logging on and trying to learn about some things. And that's kind of the intention of my presentation today as well. And it's actually going to complement not only the sponsor at Atria, but also a little bit of what Dr. D was going over a bit. And he used the word morbidity a little bit. That's really what I end up talking about. So you can kind of see my credentials on the board. You know, again, you're welcome to reach out. That's not the idea of this today, but just so you know who I am. I even put my LinkedIn profile up there. I do work with Adriani Medeiros. We kind of work together, and like to use an analogy, just coming off a doctor's presentation, Adriani's more of like a general practitioner, right? She helps people with life insurance planning. She does retirement planning, and she does long-term care planning. But I'm a specialist, so all I do is help people plan for long-term care events in retirement. I do not take on any clients of my own. So, Mary Beth did mention I'm with New York Life. I live in New Jersey. I live in Middletown, New Jersey. In normal times, I work with New York Life agents and financial advisors throughout New York, New Jersey, Pennsylvania, and I educate. So I do a lot of these seminars, right, like webinars now in today's environment. I help people, I help financial advisors learn why or who they should be talking to about this. Sometimes I work with financial advisors who've been doing this longer than I've been alive, and we make sure we're doing the right thing for their clients. So I think that's why, I was asked to at least speak on this call and kind of go through it. Now, before I go into anything financial or anything like that, I really just want to level set, and I want to make sure this is useful for everybody on the call. So when you see long-term care, like which is like the presentation, right? People tend to have some preconceived notions when I come in here. They're automatically thinking about insurance, typically, just the way that it's phrased. But I tell you, I've done this all over the country. So I've been at New York Life 13 years. I've been doing this specifically for the last 5. People tend to think about nursing homes. That's the number one thing. Like if you just hear long-term care or long-term care insurance. So I'll talk about that to start. They tend to think like the insurance, as an example, is expensive. So I'll kind of address that and give you some sense of the way we view that. And the third thing they always think about is like, this is for really old people, right? It's time to do it then, right? What I would tell you is I'll address that, but we're going to talk about planning here, right? And kind of the foresight to put some controls in place. That way, if God forbid something does happen from a healthcare or health event standpoint, we have some financial controls in place. So let's start with the nursing home piece. I can tell you there's a couple of reasons people tend to think about nursing homes with this. Number one is the technical definition of long-term care. If you go out there and you look how any insurance company or how the government defines long-term care insurance, you're going to find these 6 verbs plastered on everything, right? They're going to call these the activities of daily living. Activities of daily living. The acronym they use is ADLs, right? And when you look at these, basically the definition of long-term care is if you are expected not to be able to perform 2 or more of these for over 90 days, then we're talking about long-term care, right? And if you look at these activities, they're very rudimentary, right? And when we imagine not being able to do them, that often puts us in that worst case setting, which is that nursing home. So I always tell people 2 things, right? Number one, when you're thinking about these activities of daily living, think about your morning routine, right? So you get up, you transfer in and out of bed and out of a couch and out of the car, right, without any help. You maintain continence, you use the restroom, you bathe, you get dressed, and you make and eat a meal without any help. So if you can't do 2 or more of those, that's like the physical definition of long-term care. The other one that's not on the screen is what they'll call a cognitive impairment. So if you think about that, maybe we're able-bodied and we're able to do these things physically, but then if you have something cognitive going on, you might need someone to walk you through them. You might need someone to make sure you're taking your medicines or you're not leaving the stove on, right, as an example, or getting in your car when you shouldn't. So the second thing I tell people to think about in addition to their morning routine is think about the conditions that actually cause the loss of these activities of daily living or cause, the cognitive impairment or, what the diagnosis is. It's things like Alzheimer's, right? Parkinson's, MS, strokes. If you're 80-something years old, you take a fall and break something, right? You might need help with these activities of daily living. When you think about it from a condition standpoint, you kind of can think about, examples in your own life. Not everybody with those conditions is in a nursing home. And I would tell you, just to kind of sum it up really nicely, there's really 3 places where we see people getting care nowadays, 3 settings, right? So we see nursing homes, they still exist, right? They're typically like a hospital-like setting, right? Just, overarching view of them. The second place that we see is assisted living communities or assisted living facilities. Those are often like apartment buildings, like it depends on where you are, right? They could be townhouses or condos. I used to do this out west for a little while, like in Arizona, they would have campuses, but they're definitely not nursing homes, right? And the third place where people get care, professionally that is home health care, right? So, home health care as an example, that's somebody like a custodial nurse coming into your residence and actually taking care of you in that place. Now, think about what I said to kind of open this up. Overwhelmingly, when I start speaking to people, they kind of think about nursing homes when it comes to this. The first thing we talk about is preference, right? So when we're talking about a plan, it's not finances, it's not insurance, right? It's, look, God forbid something were to happen, what's the setting? Where would you want to get care? Where would you want your spouse to get care? Sometimes if we're speaking to people who are in their 30s or 40s, they're thinking about their parents. Where would you want your parents, to get care? And overwhelmingly, it's not a nursing home. And I would tell you it's either assisted living, it's a lot of home health care, but these all kind of play together. And what I would we call it the span of care. People usually choose to stay at home if they can up front, right? Then if their condition progresses, or maybe their, whatever their circumstances, they might start out in assisted living. But I would tell you the vast majority of people we sit down with, what they're trying to do with this planning is they're trying to age in place if they can. They're trying to put some controls in place. And what they're trying to really do is avoid a nursing home if any of those things happen. I would tell you this is really nursing home avoidance more than it is about nursing homes. Now, that being said, when I go over at a high level, like the insurance and the financial strategies, these are the costs that we're talking about. And that leads me to the next piece here, which is where people are getting care, right? The vast majority of care, and I don't mean professionally, and I'll elaborate on that in a second, it's at home, right? So people actually start their care at home quite a bit. You think about the Alzheimer's and things like that. It's not like you forget everything tomorrow. It's kind of progressive, a lot of this stuff, right? The thing about it is it's not always these home health care agencies that are providing the care. In fact, the bulk of the care is being handled by family members, right? So sometimes we'll call this unpaid caregivers. And just there's some stats on here, right? And I'll kind of allude to a few of them. But the second thing we look at in a plan typically is the family situation, right? Some of us, maybe you do have kids locally, or maybe you do have a spouse as you enter retirement. And we try to take that into account when we're looking at the preference and how you can stay at home. Now, here's what I'll tell you. Number one is it's usually a generation below the person who needs care that ends up doing the care itself. While it's nice to have someone that you might go into retirement with, the reality is most of these conditions, again, there's exceptions, right, where people have things happen earlier or maybe later, but the vast majority of them, late 70s into people's mid 80s, right? Most couples, as an example, that we work with, they're of the same age or pretty close, so they plan to age together. They're not usually physically qualified for that job when it comes. So here's what we're finding is it's the generation, or sometimes even two generations below, that are providing that home health care. So you'll see here the average caregiver from this particular survey was 45 years old, right? If you want to do some kind of side research, if you will, there's something called the sandwich generation you can look up. That's these adult 30, 40, 50 something, sometimes 60 something year old folks who have to take care of their parents and potentially, right, especially in your 40s and 50s, take care of the generation below. They're sandwiched between the two. And the rest of the stats there, what that alludes to is this is a lot of work for somebody, right? So a lot of times these days, I would tell you from a physical and time perspective, especially for those who are in their 40s and 50s, right? Do they have kids of their own and careers of their own? It's not like it was a couple generations ago where there was necessarily always someone on hand. Families are starting later for those folks, right? A lot of two-career households as an example. So family, I would tell you, has become less of the preference. And in fact, I would tell you the vast majority of people that we sit down with, they blatantly say the purpose of them looking at this is to avoid them being a burden on their family. And that's the intent. And this is the time perspective. The other thing to take into account for those folks, right, who would step up and provide the care is the financial piece too. Now, the top part of this kind of talks about them paying for things, which may or may not be the case for certain people. But I'll tell you what you can't really get around is the bottom kind of part of this slide. And essentially here, what you need to think about is that care feels free to us, right, if we're receiving it. But for that person giving the care, not only is it emotionally or physically taxing, you're talking about them potentially working less or not being able to work, not contributing to their own retirement plans, maybe losing some of their own benefits or social, whatever it might be. So really, I would tell you, it's not just planning for the individual who's doing the planning, it's planning for the entire family unit, because families usually step up and try to take care of you if they can. That leads me to the next part. So I explained that people usually come in saying, that insurance is expensive, right? Sometimes we don't even talk about insurance with people. This depends on their circumstance, which I'll go over. The insurance is optional, right? But I'll tell you what's not optional. It's planning to grow old and potentially needing help. Now, this I just took, like I live in, I knew we were dealing with mostly Monmouth, Ocean County here, right? So I just pulled the local cost. At the bottom of this screen, you'll see a resource you can use. Maybe you are a snowbird, or maybe you plan on retiring somewhere else. The cost will be a little bit different. So you can actually kind of play with the geography here. What I'll tell you that's pretty interesting about this is these are the costs today, number one. A lot of the folks who we're doing this planning with, which I'm going to elaborate on in a second, they tend to be either pre-retirees or recent retirees. So I would tell you 50s, 60s, 70s, right, is where a lot of the planning happens. And don't get me wrong, there's some exceptions there, but that's the bulk of it. A lot of these folks are not planning on taking out insurance to use it tomorrow. And in fact, you can't do that, right? They're doing it 10, 15, 20 years ahead of hopefully nothing, right? But when they expect where something could happen, these costs will go up over time, right? They will increase just like everything else does. The second thing is, if you don't put any controls in place, what is the portfolio? What do your assets look like if we have to spend that money on care, right? Now, what's wildly inconsistent across the United States is kind of the top part of this table, right? I'm going to sum them up here, like assisted living and nursing homes, right? And they're very different in cost, right? But what I'll tell you is those are very real estate driven costs typically. Those are averages, so they could be higher or lower, but it gives you a good sense of what to expect around here. What's very consistent, though, across the country is the bottom part of this table, which is, in particular, the home health care aid hourly rate. So if you're trying to think about the financial perspective of this, if you start doing the math on, nursing homes, 150 grand plus a year, assisted living, somewhere between 40 and 70 grand a year, which it depends on how nice it is, where it's located, how much care you're receiving. But if you're looking at home health care, if you just start doing the math on 5, 6, 7 hours a day, 5, 6, 7 days a week, right? You're talking $50,000, $60,000, $70,000 a year potentially, for home health care, and that's not necessarily around the clock care. What's very expensive is not planning for these costs, or planning for the costs and then trying to pay them out of pocket, right? So when we get to the examples here of like the funding sources, again, I'm going to kind of do like a Reader's Digest type view, right? The idea is, look, how do we plan for these costs, and do we have enough money to handle them? And even if we do, if we look at insurance, which we don't blanket recommend to everybody, it's to partner it with the income and assets that we have to potentially stay at home, to afford the assisted living, to avoid the nursing home if we can. And I'll segue into the financial piece here. I'll tell you, this has become part of retirement planning. I work with financial advisors and agents. I've done this all over the country, like I've said, and they would tell you in the last 15, 20 years, this has moved to the forefront where it's become an essential part. And it's for two reasons. One of them, the doctor had mentioned, right, is longevity. We just simply have people living longer lives. So they're higher risk when you live a longer life for those conditions, the Alzheimer's, dementia part, those things to act up at that point or show themselves, right? That's number one. Number two is the way people have retired over the last couple decades, right? I would tell you there's a lot less pensions. There's a lot more people having to save for their own retirements. That's not saying that people with pensions don't do the planning, but it's a little different for them. The folks who have 401ks, IRAs, or are self-funding their own retirements, they have finite resources. So it's very difficult to plan to live a long life if everything plays out perfectly. Never mind if we have to start writing checks for home health care, assisted living, nursing homes. And that's the overarching problem, right? Is hope is not a strategy, right? Put some controls in place. And the idea is if we put some controls in place, you have a higher chance of staying at home. You have a higher chance of not being a burden on your family. And you have a higher chance of making your portfolio extend, right? So that it will last as long as you, and if you have a spouse, as long as they live as well. All right. Here's what a plan looks like, right? So like we covered some stuff. I'm going to tell you what's not useful, right? If you know your plan, right? You know where you want to get care. You know you do or don't want your family involved. You know where your funding arrangements are, retirement assets or insurance are. That doesn't help a lot of the time. And the reason is when those disasters strike, we often can't articulate, right, to the folks that love us and are providing the care what the plan is. So my advice is, even if you have something in place, make sure one of your family members has a copy. Make sure, like I'm not an attorney, or maybe you have an estate attorney or accountant you work with. If you do end up working with us, give a copy to Adriani as an example. That way, if something does happen, we know you have a strategy in place. Now that being said, and again, I'm going to try to do this kind of quickly, right? So just so that I'm within the time limit here, these are kind of the three places or the three ways, pardon me, that people seem to think or that care is actually paid for. Now, anything I go over here, the intent is not a recommendation. It's more to kind of get you thinking about your own situation and potential questions to ask yourself or a professional, right? So the first thing I'll just cover here at a high level is paying for this out of pocket. That's the default option. If for some reason you don't want insurance, you can't get insurance, whatever it might be, if you have income and assets set aside for retirement and you're using, and something happens, you're going to have to look at your retirement assets. Now, some folks we work with even might make a decision beforehand, before they retire to self-fund or self-insure, but there's some strategy around that. So usually some things that we take into account with like an emergency fund for this is we try to take it into account the tax situation of a withdrawal, right? So things like IRAs and 401ks, they create taxable events. So we try to look for money that won't cause a taxable event. Not always, but that seems to be something that we look at, right? Second thing we look at is liquidity, right? So if you own real estate or you're a business owner, we might make sure you have some liquid money on hand. That might be cash, but one thing with cash is it might not keep up with that inflation component, right, as an example. And the third thing we take into account is how aggressive your money is invested, especially the older you get. And again, not a blanket recommendation, but we try to look at what we use the word diversification quite a bit. We try to look at safer assets for an emergency type fund because we can't predict on when we're going to pull it out. We don't know how long we have for the money to grow, and we can't predict what variable money might be worth when it's time to pull it out. So I'll say this, the more information we have as professionals, the better job we can do in assessing what your strategy might be, or if we recommend insurance, the intent would be to wrap it around what you already have in place, being it a pension or your own assets. That leads me to the next piece, which is the government. Now, again, I'm not going to go crazy on this just for the sake of time, but I'll tell you this, it is incredible how many people think the government is just going to automatically pick up their long-term care costs. Long-term care being home health care, assisted living, nursing home. Now, what you see on the screen, they just talk about Medicare here, kind of health insurance. Now, the doctor did a great job. He's talking about preventative health, right? Medicare typically picks up like preventative health, acute health, rehabilitative health to some degree. But what Medicare doesn't do is after 100 days, and in a lot of cases, there's no coverage at all for any of this, but in a worst case scenario, they pay up to 100 days in a nursing home type setting with a rehab component. But no Medicare, even if you have the best supplement or advantage plan, picks up after 100 days. So really it's temporary care in a worst case scenario. The one that people tend to confuse and think that they'll automatically qualify for is Medicaid. Now, Medicaid is a joint run state and federal program, so there are some state by state nuances, right? But Medicaid, you have to financially qualify for. So just the limits on the board, right, are on the screen, pardon me. They're more about, like this is like New Jersey as an example. They might be a little different across the river. They are a little bit different. They're pretty similar in Pennsylvania. They look at two things. They look at how many assets you have, right? So you'll hear the word Medicaid spend down. So if you have some assets set aside, they're going to make you spend down to a certain amount depending on your marital situation. So for single folks, so be it widowed, divorced, or just entering retirement single, they get to keep $2,000 worth, right? For those who are married, right, as an example, but one person needs help and the other doesn't, you get to keep $126,000 in change combined. And if, God forbid, both people need help, you got to spend down to $3,000. It's really a welfare program for those who unfortunately ran out of money over time, right, or entered retirement with very little, all right? The other thing you should ask about, again, I am not a Medicaid attorney or anything. I'm just kind of trying to give you the information here, and you can see the resource at the bottom there. They'll get your income as well. They count Social Security, they count your pension, they count annuities, they count real estate or business income. For single folks, you can't have more than $2,000 a month coming in, and for married couples, it's a joint $3,000. Here's my point. We don't blanket recommend long-term care insurance or insurance solutions or any the planning to everybody. We typically work with people who have some income and assets set aside because, quite frankly, if you don't have that money set aside, you're probably looking at what Medicaid provides. Final thing on Medicaid is you lose control over where you get care, right? So God forbid something happens, the state kind of tells you what you're eligible for. A lot of Medicaid care, especially in New Jersey, is in that nursing home type setting, the very thing we're trying to avoid with the planning. I'm going to try to just at a high level, like this could go, underwriting. When I get to the insurance here in a second, right, people want to know price. 4 things drive price. Your age and your sex are 2 of them, right? So the older you are, the more you pay. We offer long-term care solutions insurance-wise between 25 and 79 years old. Again, most people we deal with, they tend to be in their 50s, 60s, maybe 70s, right? And the reason it's maybe 70s is the third thing that controls price, which is your health. They do medical underwriting for this. Now, I can't possibly cover everybody's conditions for this, but I'll tell you a little bit about it. Number 1, it's not invasive. No one's coming to your house, right, or trying to take blood or urine typically, right? As long as you've been to a doctor in the last year and a half, 2 years, no big deal there. They'll test your memory if you're over 60 years old. They do a cognitive assessment, so don't joke around with that person if you go the insurance route, right? They're worried about Alzheimer's, dementia. And then they'll ask you about your health history and request your medical records, okay? My advice to anybody is don't disqualify yourself, right? I think you'd be surprised at what they're looking for this type of coverage. The more you disclose to the professional you're working with, the better, right? Because they're trying to give you an accurate description of price and whether you're eligible. They'll typically, like the best thing I could tell you advice, your height, your weight, medications, surgeries, and any conditions, specifically like memory or nerve or bone type conditions. And that would give us a really good sense of what the price would be. The other piece here, those 3 things we can't control, pardon me, your age, your sex, and your health. You kind of come to us that way, right? But the one that we can manipulate is the type of insurance you get. There's all different types of solutions and the amount that you buy. Now, that being said, again, kind of the Reader's Digest version here. This is like what a typical long-term care plan might look like, a couple of variables. We can manipulate how these plans work. So you can do things like buy certain daily caps. You can buy certain durations. You can buy different amounts of coverage. Just as like a rule of thumb, like without me getting too insurance-y on this, right? Most people tend to buy something like where we live, like $150,000 to $300,000 worth of coverage for each person. They're trying to insure home health care for a few years, assisted living for a few years. They're trying to partner that insurance to stay out of the nursing home, but also to pay for it with your assets if you needed to, right? So depending on your age, your sex, your health, the amount of coverage, that's how we'll get to price. And there's a lot of people on this call, none of which that I know. It would be unfair for me to give some sort of quote, but I'll tell you this is like homeowners insurance typically. So we try to budget for it. We can manipulate the deductibles and inflation and things like that. We try to hit your budget. It usually goes from like $100 a month up to $400 or $500 a month. And that sounds like a big gap, but there's a lot of different ages. There's a lot of different healths. It's a lot of different amounts. We try to tailor it to hit your situation. I'll end it here. I'll leave this up on the screen. I'll let Mary Beth pop back on. I hope this was helpful. Again, we try to squeeze a lot into a shorter presentation. again, no recommendations as far as get insurance, don't get insurance. But my advice is don't ignore this problem, right? Because if something does happen and you don't have the controls in place, it's chaotic for your family and for yourself. And if you make some plans and nothing happens, no one's going to complain about that. But I really do appreciate the time. I hope that was helpful. And I've had my screen shared, so I'm not sure if we have any questions or not, Mary Beth.
We do. So one of the questions was, how much time should be spent in discovery when determining if long-term care is right for you? Because this is a process.
Yeah, great question. All right, so I'll give you some generalities here. So some folks work with us just on long-term care planning, and for some folks, we're full service financial planning. That's my first. So it depends on what you're trying to do. Like if you have a financial planner or something, or you're doing your own and you're comfortable with that, we try to complement what you're doing. So it might be a shorter discovery process. Now, if you want to have your entire, financial picture looked at and make sure, have us incorporate this that way, it might be a little bit longer. If you want like the high level version of it, if you share with us like your income, overarching picture of your assets, and the general picture of your health, we can honestly give you a pretty good idea of whether you should be looking at it. And if we think between everybody, all parties, that insurance might be the play, or we usually just ask you to go through underwriting, because the last thing we want to do is show you a price, then you come back through the health underwriting and it's something that we didn't anticipate, right? So I hope that answers the question.
Okay. We have a question. What is the difference between long-term care and a chronic care rider for a whole life policy?
Yeah. So here's what I'll say, right, is there's a lot of different types of insurance vehicles out there. All right. So if I had to break it down into kind of two different types, all right, one is long-term care insurance. All right. That one we can kind of manipulate. It's usually the lowest cost option. It's more of a specialized product, right? So I mentioned it's like homeowners insurance to that regard. There's not a death benefit or cash value in it. We should be complementing the portfolio with that one, right? That's going to be like a monthly premium or like an annual premium. Sometimes you can tax deduct that as an example too. It depends on your circumstance. I'm not a CPA, right? We refer to your CPA for that. But on the other side of the coin, like a chronic care rider, or they'll even use the word hybrid policies, those are joint life and long-term care policies. So they usually have three benefits to them: a long-term care component, a life insurance component that would pass on if you didn't use the coverage, and the third is a cash value component. The big difference is cost or capital. The hybrid or the rider is going to just cost more money usually. That doesn't mean it's the wrong answer, but that's for a certain person because they're trying to do three things inside of one product. And the last thing I'll say on it, one is not better than the other. That's the key. If we have a better idea of your financial circumstance, we'll try to steer you. We'll give you the options, but we'll try to steer the right way. And sometimes we even blend some of the solutions together to create like an insurance portfolio.
Okay. And I would say finally, we have a question. On average, Mike, what would you say is the average age people are purchasing long-term care insurance?
Yeah. So I'll tell you I get that question quite a bit. Now I've done this with people in like their 20s or 30s, which I'm not telling you is the right age, right? But maybe they had a family history or something like that and they came to us, right? Or they were already at their backyards. Then I've worked with some people who are in their, 70s, well into their 70s. The key in that range is health, right? The key, just the reality of it is underwriting is going to be tougher there. And sometimes it becomes cost prohibitive, not all the time. The bulk of the people who we work with, they tend to be in their 50s and 60s. Okay. What's more important to me than your age is your financial circumstance, to be honest with you, right? Because you might be the right age, but if you don't have the right things in place already, right, then we won't recommend it. And that's what we try to do, the right thing for each client.
Okay. So it sounds like you really want to make sure you're working with a good partner, because there's a lot of good conversations that need to take place in all of this.
Yeah, thanks again. And like I said, this is what we do. I look at long-term care plans all day. Like if you have a long-term care plan, you want it reviewed or something, we do that. There's not a charge for that or anything. And I left that information up. I know Mary Beth will send it out afterwards, she mentioned too. But the intent is for you to make an educated decision and just kind of know what the options are.
Great. Well, thank you so much for joining us today, Mike. I'm going to close us out. Andrea still has a frozen screen. Bye, Mike. Have a good one. Thank you.
Yeah, thanks for having me.
You're welcome. So I want to thank everyone for joining us today. I'm just going to go over a couple of things I want to share with everyone. This webinar is being recorded today, and we will be sending it out to all our participants if they want to watch it again or share with family and friends. We do have 3 gift card winners that will be selected from our participants of the webinar today. We'll share that as well in our thank you email. Our next virtual event will be on August 25th. It is going to be a breakfast event, and that will be held from 9:30 to 10:30 a.m. Registration for that will be available come next week. In addition, I wanted to share that our fall semester will continue to be online. Our classes and events will continue to be online. Registration for that should be opening in about 2 weeks. So stay posted with SCAN on our website at www.scannj.org. And if you are part of our mailing list, check your emails regularly. And again, I would like to thank today's lunch sponsor, Atria Senior Living, and Care One and New York Life for presenting our topics today. And when I finish, we will have a screen up that gives the contact information for our sponsors and our presenters. So again, I'd like to thank everyone for participating today on behalf of SCAN and Andrea. Thank you again for joining us.